We all get old, and at one point or another, our bodies get old too. In the circle of life, we all have to experience certain events. Let's talk about menopause. Menopause is defined as a period of menstrual irregularity, the climacteric, a period of life when fertility and sexual activity are in decline, followed by the cessation of menstruation. The mean age of menopause is around 50 years. However, some literature consider individuals having experienced these changes before the age of 40 as to having premature menopause. Causes of premature menopause include genetic conditions such as Turner's and Fragile X, endocrine disorders such as Addison's and diabetes, metabolic causes such as galactosemia and 17-alpha hydroxylase deficiency. Signs and symptoms of menopause are attributed to the hormonal changes seen during this period, and these include vasomotor features such as hot flushes, night sweats, palpitations, tissue atrophy affecting the vagina, breast, and skin, urinary changes that may involve stress incontinence, mood changes such as irritability and being tearful, cognitive and psychological features such as tiredness, sleep disturbances, poor concentration, and memory problems. Individuals may also experience osteoporosis that may predispose them to pathological fractures. A mnemonic to help you remember these clinical features is known as FEM changes. F for flushes, E for emotional features, M for memory problems, C for concentration problems, H for hydrosis, which are night sweats, A for atrophy, N for no sleep, G for genitourinary symptoms such as incontinence, E for extra beats or palpitations, and S for skin changes such as atrophy. The differential diagnosis of menopause includes thyroid disease, diabetes, anemia, and psychological problems. Investigations are rarely needed. However, an individual may need 2 follicle-stimulating hormone or FSH measurements 1 month apart showing levels more than 30 millimoles per liter. This tends to confirm menopause. Recall that the production of FSH is under negative feedback through estrogen, which is produced by the follicles in the ovaries. In the case of menopause, the follicles in the ovaries atrophy, and this negative feedback is abolished, resulting in a rise in FSH. An abdominal examination, vaginal examination, and speculum may sometimes be indicated. Many women do not require any specific therapy. However, hormonal replacement therapy, or HRT, may be considered in women with symptoms such as vasomotor, vaginal dryness and atrophy, low mood, and osteoporosis. Though hormonal replacement therapy is no longer licensed for anti-osteoporosis alone, so the usual osteoporosis treatments such as bisphosphonates should be considered if this is the only symptom. Hormonal replacement therapy can be made through combined estrogen and progestogen, or unopposed estrogen, which is often used if the patient has had a hysterectomy, as there is no increased risk of endometrial cancer. When starting hormonal replacement therapy, the lowest dose for least time possible, starting low and working up until symptom relief is taken. It is usually after 5 years. Before initiating hormone replacement therapy, ask about risk factors, past medical history, and family history of conditions whose risk hormone replacement therapy may increase. Make sure to warn women that vaginal bleeding in the first 3 months should be reported. Cyclical hormone replacement therapy with daily estrogen and a progestogen only in late cycle may be used if there is still irregular bleeding, or a continuous approach with a daily estrogen and progestogen contraceptive can be done if the last menstrual period was over 1 year ago. Usually, the route of administration of these medications is the oral route. However, estrogen is also available through vaginal creams, pessaries, and rings for vaginal symptoms. Other options include transdermal patches, which are better if venous thromboembolism is a worry. Implants and gel can also be used. Side effects of estrogen include nausea, pain, headache, tender breasts, leg cramps, sodium and fluid retention, which may increase blood pressure, while its progestogen side effects include bloating, irritability, depression, acne, and increase in facial hair growth. Contraindications to hormone replacement therapy include a personal or family history of breast, endometrial, or ovarian cancer, presence of a breast lump, other gynecological conditions such as fibroids, endometriosis, undiagnosed vaginal bleeding, and non-gynecological conditions such as a migraine with aura, systemic lupus erythematosus, liver disease, uncontrolled hypertension, and a personal or family history of venous thromboembolism. It is important to remember that some of these conditions are not absolute contraindications. Alternatives and adjuncts to hormonal replacement therapy include moisturizers and lubricants that can be used for vaginal atrophy, as well as other medications that may help with vasomotor symptoms. These drugs include clonidine, an alpha agonist, a selective serotonin reuptake inhibitor, and gabapentin. For women on contraception and above the age of 50 years, they may continue for 1 year. But for those less than 50 years, they do often continue for 2 years. It is worth mentioning that contraception carries an increased risk of certain conditions such as cancers, including endometrial, breast, and ovarian cancer, as well as stroke and venous thromboembolism. There is, however, no good evidence that hormonal replacement therapy affects the heart or increases the risk of dementia.